Hello and welcome to A1C to Z, the ABCs of diabetes. My name is Christina Bowie and I'm a nurse practitioner specializing in endocrinology and diabetes. I created this video series a few months back to help my patients better understand the disease process of diabetes and how it affects their body and how to control it, and pretty much everything else about diabetes. But I wanted to take some time to make a video for nursing students and nurses specifically to go into a little bit more detail. And of course, my patients are welcome to watch this as well. If you have any questions or if anything is hard to follow, just comment in the comment section and I'll get back to you. But basically, I want to talk about some of the things that the nurses are responsible for when it comes to managing diabetes. I want to talk about the anatomy and physiology of diabetes and the pancreas, the different types of diabetes, complications of diabetes, types of insulin, and management of diabetes. We are responsible for keeping patients' blood sugars well controlled when they're in the hospital, and we should take that responsibility seriously. And by the end of this video, you will understand why. So let's talk about the pancreas. I'm not a great artist, and this is not to scale, but this is kind of what your pancreas looks like. It's got these little clusters of cells on it, which is called what? The islets of Langerhans. And within the islets of Langerhans, you have two main types of cells. We've got alpha cells and beta cells. The alpha cells do what? They produce glucagon. And the beta cells produce insulin. Now, before we go any further, we need to talk about a concept that is central to anatomy and physiology. I'm sure you guys all learned about this concept in the very first chapter of your anatomy and physiology textbook, and it is called homeostasis. The body is in a constant state of equilibrium. That is what the term homeostasis means. It means that the body has a very good system of keeping everything in balance, in the right equilibrium. If something gets thrown out of balance, that means there's a problem and it needs to be corrected. For example, your pH of your blood is kept very, very specifically between 7.35 and 7.45. Anything outside of that very narrow range is abnormal, and then we term that either acidosis or alkalosis, depending on what's going on. Same thing with the blood sugars. A normal blood sugar is between 70 and 100. Sometimes people have normal blood sugars in the 60s. That's okay if they have normally fasting blood sugars in the 60s, as long as they're not symptomatic, that's not a problem. So they may occasionally go higher than 100. But if we have frequent fasting blood sugars between 100 and 120, this is considered to be, more specifically 100 and 125. This is considered to be prediabetes. Two fasting blood sugars greater than 126 is considered diagnostic for diabetes, okay? So it's a very narrow range of normal blood sugars, maybe like mid-60s to 100, okay? And the way the body keeps this in check is that the alpha cells and the beta cells balance each other out. So glucagon is a hormone which causes the liver to release stored glucose. Insulin is a hormone that allows the sugar in your bloodstream to be taken into the cells and used for energy. That's when that can't happen, when there's no insulin, or if the cells don't respond to insulin, then the glucose stays within the blood, and this causes the blood sugars to go very, very high. The cells can't get this glucose for energy, and they think they're starving, even though there's so much sugar in the blood, but the cells don't realize that. They start to break down fat and muscle for energy, and this is when we develop ketosis, and when patients go into diabetic ketoacidosis. So basically, when you eat something, if you didn't have any insulin, your blood sugar would spike like that. But because you have insulin that's released simultaneously, it covers that sugar and keeps it within a normal range, okay? So we're gonna say this is 100 and this is 120. So it keeps it within this normal range because you have that insulin that was released. When your blood sugar starts to drop below, let's say, below, sorry, this is supposed to be 100. This is 100 and this is 70. When your blood sugar starts to drop below 70, what happens? Say you're sleeping, you're not eating anything, your blood sugar starts to dip. Your pancreas alpha cells release glucagon, and then glucose is released from the liver. And so this brings this blood sugar back up into like our normal range. And that keeps you from getting hypoglycemic during the night. So now that you understand a little bit about how diabetes, or how a normal pancreas works, let's talk about the different types of diabetes and what is going wrong when patients have diabetes. So the different types of diabetes, let's start with, let me draw a line here. Let's start with type 1. What do we know about type 1 diabetes? First of all, it's an autoimmune disease. And what does autoimmune mean? It means that the body is attacking its own pancreas. And over time, it destroys the beta cells of the pancreas, which make insulin. And when enough beta cells have been destroyed, then the pancreas no longer makes insulin. And this is when the patient goes into usually DKA and gets diagnosed with type 1 diabetes. What else do we know about type 1 diabetes? They're always insulin dependent because the pancreas does not make insulin. So they have to have insulin. Always insulin dependent. So what happens if the patient doesn't get their insulin? Then the patient goes into DKA. This is a life-threatening complication of diabetes. You never ever want to be the reason why your patient went into DKA. There's a lot of paperwork involved with that, and it's not safe for the patient. Okay, you don't want to be on the receiving end of an incident report because you held the patient's insulin inappropriately and the patient went into DKA. It's never a good thing. I've seen that happen at least a dozen times since I've been working in endocrinology for the last couple of years. What else? A lot of times type 1 diabetics are very thin. Lifestyle factors don't have much to do with, it definitely helps them control their diabetes, but as far as preventing the type 1 diabetes, lifestyle factors don't play into that. There's really no way to prevent this. With the type 1 diabetes, we need to do the best we can to control it, just like with any other type of diabetes. But definitely, with the onset of obesity and the obesity epidemic, we often see now type 1 diabetics who are actually obese or overweight. So you may see some that fall outside of this stereotypical type 1 diabetic who's typically tall and thin. And we are also seeing type 2 diabetes diagnosed younger and younger. So now the lines are being blurred a little bit more. Patients may need more in-depth testing for us to know for certain which one they are, if they don't meet one of the stereotypical classic presentations of either type 1 or type 2. And then we have type 2. And what do we know about type 2 diabetes? We know that there is a genetic component. It tends to run in families. And we know that there is a lifestyle component. Which one of these things can we modify? You cannot modify your genetics. If you're genetically predisposed to diabetes, then you may develop diabetes even eating right and exercising regularly and keeping your weight at a proportionate weight. But we can modify the lifestyle factors, and that will at least give you a better chance of not developing type 2 diabetes. And if you do develop type 2 diabetes, then it gives you a way to prevent it from escalating and to keep your blood sugars better controlled and prevent those long-term complications of diabetes. And so with lifestyle, we have eating habits. And for a good video about carbs, I have another video called Diabetic Diet Revised. Well, check that one out. Exercise. And maintaining a healthy weight. Those are all things that you definitely have control over, and you can do the best you can to prevent type 2 diabetes from happening, even if you have a family history of type 2 diabetes. What happens with type 2 diabetes? When you have type 2 diabetes, your body makes insulin, usually. But your cells don't respond to the insulin. They become very insulin resistant. And so when your cells don't respond to the insulin, the glucose can't get into the cells where they need to go to carry out the bodily functions. And so that's why the glucose stays in the bloodstream. The blood sugars are so high, and we have this cascade of events that happens. So we need to do something to help the insulin get increase the amount of insulin, or decrease the increase the sensitivity to the insulin, or whatever we need to do to help the type 2 diabetes patients with type 2 diabetes respond to their insulin. The other thing that we can say about type 2 diabetes is that we are seeing it diagnosed younger and younger these days. So you may have 12-year-olds who have type 2 diabetes. It just is very hard to say sometimes whether a patient has type 1 or type 2. Sometimes they'll just try them on pills and see how they do. But that brings me to type 2. Can be managed with pills. Can be managed with pills, okay? Are there type 2 diabetics who are insulin dependent? Yes, there are. So why do some type 2 diabetics become insulin dependent? It's because diabetes is a progressive disease, and just like how it damages the other organs of the body, the pancreas can become damaged and lose beta cell function. And once a certain number of beta cells have been destroyed from the pancreas, they don't regenerate. They're gone forever. And so if the pancreas is no longer producing sufficient amounts of insulin, then a type 2 diabetic will go to acting like a type 1 diabetic. We frequently see type 2 diabetes in DKA. That happens frequently, and it used to be that type 1 diabetes was considered insulin dependent, type 2 was considered non-insulin dependent, type 1 was, if they went into DKA, they were considered type 1, and so forth like that. But the lines now have been so blurred between the two that it does happen. We need to prevent this type 2 diabetes from progressing to the point where they're insulin dependent. We want to get them to where they can be managed with pills or with diet or with both. The other type of diabetes that I want to talk to you about real quick is gestational diabetes. And those of you who end up working in women's services will come into contact with gestational diabetes. So with gestational diabetes, there's a few key points that we need to consider. We no longer are concerned about just one person. Now we're concerned about two people. we have a very strict guideline with gestational diabetes that we want to keep their blood sugars very, very well controlled. We want that fasting blood sugar to be less than 90, and we want their 2-hour postprandial, that's 2 hours after eating, glucose to be less than 120. So, this is much more strict than what we usually will want our type 1 and type 2 diabetics to be controlled at. And the reason for this is because when the blood sugars are not as close to normal as possible, then it puts the infant at a very high risk of complications, including stillbirth, premature delivery, large for gestational age, which increases the risk of cesarean section, all kinds of things like that. It also puts the infant at risk for hypoglycemia after it's born, if the mother's blood sugars are not well controlled in the hours leading up to delivery. So this is really, really important. The other thing with gestational diabetes is that it corrects itself immediately after delivery. So it's like somebody flipped a light switch off, and 1 minute they had gestational diabetes, the next minute they don't. So usually we see those sugars correct and go back to normal levels immediately. What we like to do with gestational diabetics is we like to bring them into the clinic about 6 to 8 weeks after delivery and do another oral glucose tolerance test. And the reason for that is because we want to make sure that they don't have an underlying type 2 diabetes that just didn't get diagnosed until their pregnancy. Because if they do, then we want to go ahead and treat it as early as possible. Let's move on to talking about the complications of diabetes. When it comes to complications of diabetes, we have 2 different types of vascular complications. We have microvascular and we have macrovascular. So what do you think that microvascular means? Microvascular obviously are the small blood vessels. So let me give you an example like this. When your blood sugar is very high, your blood is very thick, like syrup, it has a really hard time getting into the blood vessels in your eyes and in your kidneys and in your feet. And so that is why we see a lot of damage to those organs specifically. Those are called microvascular changes. And so the most common ones that we see are retinopathy. That's damage to the eyesight, which ultimately leads to blindness. Nephropathy, which is damage to the kidneys, which ultimately leads to kidney failure and dialysis. Peripheral neuropathy. This is an especially difficult complication. What happens is that the blood sugars cause the blood to be very thick. The blood can't get to the tiny blood vessels in the feet, sometimes the hands, but usually the feet are affected. And that damages, the lack of oxygen damages the nerves in the feet. And so the patients often report numbness and tingling and sometimes pain in their feet when this starts, and then eventually it progresses to complete numbness of the feet. And if patients can't feel their feet, they don't know if they've stepped on a piece of glass or a nail or something like that. And so they may have a wound for a week or 2 weeks until it becomes infected, and they don't even notice until it becomes a problem. And so now we have a wound, we have a lack of circulation, and what do wounds need for healing? They need oxygen. We have a lack of oxygen, so we are going to have poor wound healing. And then we have this very high sugar environment. And so that is a perfect breeding ground for bacteria. So now we've got this trifecta of events going on that is going to cause this wound to snowball out of control. And ultimately what we see with that are we see amputations. And we want to prevent that. In addition to just the injuries from, even in the absence of an injury, we see diabetic foot ulcers, which are just simply ulcers that heal from a lack of circulation. Ulcers that form from a lack of circulation. We see abscesses that come out of nowhere because of the blood sugars being so high, and so it just develops this infection. And all of these things snowball, and we do the best we can to keep the blood sugars controlled, give the patient antibiotics, do appropriate wound care, but sometimes we cannot get these wounds to heal up especially if the blood sugars are not well controlled. And so that's why we see diabetic patients who end up with amputations. The other things that we don't hear about as much, but are still pretty common, are we see a lot of gastroparesis. And this means, this is just like peripheral neuropathy, except it happens to the stomach. And so what happens is the nerve damage to the stomach causes a slowing down of the motility, and so the stomach doesn't empty like it's supposed to. And this causes a chronic nausea and vomiting with patients who have gastroparesis. And so what we need to do with those patients is we need to get them on a gastroparesis diet, which I will later go and make a video about a gastroparesis diet. But we need to get them on a special diet, and we need to keep the blood sugars controlled. Can we heal the damage that's already been done? Maybe some of it, but probably a lot of the damage that's already been done is permanent, but we can prevent it from getting worse, because gastroparesis makes the diabetes much more difficult to control because the diet is so erratic. The gastroparesis makes the diabetes worse, the diabetes makes the gastroparesis worse, and this is a continuous cycle. We have to break that cycle by getting the blood sugars controlled and getting the gastroparesis controlled. The other thing that we don't hear about very often, but I want to mention it, is erectile dysfunction. This is something that should really be stressed to some of our young men who have diabetes, to make them understand how serious the disease is. Just like with the other organs, the penis is very high in blood circulation, and it's very high in nerve fibers. And so when those nerves become damaged, it leads to erectile dysfunction. So these are our microvascular changes that we see. Now, macrovascular means what? Large blood vessels. And so what does that mean? That means that our patients are at an increased risk of what? Increased risk of heart attack and stroke. So if your patient came in with a heart attack, are they already at an increased risk of having a second heart attack? Yes. If they came in with a stroke, are they at an increased risk of having a second cardiovascular event? Yes. Any cardiovascular event puts them at risk of having another one. What can we do to help prevent that from happening? We can keep their blood sugars controlled. No matter what your patient is in the hospital for, their diabetes can negatively impact their hospital course. If they came in for surgery, even if it's a lap chole, whatever they came into the hospital for, if they came in for surgery and their blood sugars are not well controlled, what do you think is going to happen? That wound is going to get infected from the high levels of sugar, and it's not going to heal because the patient's going to have poor circulation. So we can do the best we can to prevent that by keeping the blood sugars well controlled. Which brings me to talking about types of insulin and management of diabetes. Now that you understand why it's so important, let me tell you how we're going to do it. So with types of insulin, we're going to break it up into two main categories: long-acting and short-acting. And then we also have combo insulins. Okay? So with the long-acting insulin, what are the types of long-acting insulins? They're usually insulin glargine is one, which is Lantus, insulin detamir, which is Levemir, where there's some new ones, Toujeo and Tresiba. Basaglar is also a newer insulin. And NPH is an intermediate insulin, but we're going to put it in the same classification with our long-acting insulins because it has the same characteristics. And our short-acting are going to be like These are the ones you're going to see most common in the hospital. Okay? And our short acting is going to be like Humalog, Novolog, and regular. And then you may see some newer ones from time to time like Fiasp or something like that, usually on the patient's home medication list. What does the long-acting insulin do? Long-acting insulin takes care of the sugar that the patient's own body makes. We already talked about the glucagon and how it causes a release of glucose from the patient's liver, and this is an ongoing process. So if the patient doesn't have enough insulin, or if the patient's body doesn't respond to the insulin that they do have, then we're going to have high blood sugars because of that lack of insulin and the production of glucagon from the liver, in addition to the glucose that we get from the food. So the long-acting insulin takes care of the sugars that the patient's own body makes. They should be able to get that whether they're eating or not without worrying about having low blood sugars. If they are having low blood sugars, with that long-acting insulin, when they're NPO, that means that the dose is too aggressive. It needs to be decreased. And is that up to you to decrease it? No. But you can call somebody and let them know, hello, my name is so-and-so. I work at such and such hospital, and I'm taking care of your patient, Mrs. Smith. Last night, she got 50 units of Lantus. Her blood sugar was 135, and this morning it dropped her blood sugar to 35. Tonight, her blood sugar is 170, and she has 50 units of Lantus due. Would you like me to give the whole dose, or would you like to adjust the dose? That is a perfectly reasonable conversation to have with somebody. If you don't call and tell somebody that the patient's blood sugars are out of whack, then they may not realize it, and they may not make adjustments to that insulin. So be proactive. You know, if you saw it happen before, you can have a pretty good idea that's probably going to happen again. So this takes care of the sugars that their own body makes, and the short-acting takes care of the sugars that is in their food. So ideally, with the short-acting insulin, we get the right amount of food and the right amount of insulin, and they cancel each other out. Right amount of food, right amount of insulin, cancel each other out. Again and again and again. And we keep those blood sugars normal because we don't want to treat the blood sugars when they're already high. We want to prevent them from getting high in the first place. That is why we give them long-acting insulin first, and we give them often short-acting insulin scheduled with meals. So when it comes to the short-acting insulin, we usually have scheduled, and we usually have sliding scale. What does the sliding scale do? The sliding scale only treats blood sugars when they're already high. Usually above 150 or 180 is where most sliding scales start. Do we want them to get to that point in the first place? No, we want to keep them much better controlled than that. So the scheduled insulin should be given with food, okay? Because it cancels out the sugar that's in their food. Only give that with meals. If you give their scheduled insulin, let's say they get 10 units, you give the 10 units with no food, what's going to happen? Their blood sugar is going to bottom out. If you give their food and you decide to hold their insulin because their blood sugar is good, it's like say 130 this morning, and so you're going to hold that insulin, you give their food, what happens? Their blood sugar skyrockets. So when you check it at lunchtime, it's what? 250, 270, 400. You have to make sure that those two go hand in hand. You give the insulin, you give the food, they cancel each other out. Then what happens? Blood sugar before they eat 130s, 140s. They get their insulin, they get their food. Blood sugars after they eat 130s, 140s. That's great, 150s. In the hospital, we'd let them go up as high as 180 because patients in the hospital are prone to hypoglycemia because of mismanagement of diabetes. So let's talk about when you should hold these types of insulin. When should you hold long-acting insulin? Never. You should never hold long-acting insulin. If the patient's blood sugar is questionable or the patient is NPO after midnight, you should call somebody and get parameters on that, or call somebody and get an adjustment to the dose. because we don't have to give the full dose. We can give half a dose, we can give 3/4 of the dose, 70% of the dose. It's very likely that whoever is writing that insulin is very familiar with the patient and can probably gauge about how much insulin they can handle. If the patient's blood sugar is less than 100 at bedtime, or the patient is NPO, call somebody and let them know. This patient's blood sugar is 132, they're NPO after midnight for a heart cath. Do you want me to give the full dose of Lantus tonight? What's going to happen if you hold that Lantus? Then the next morning their blood sugar is going to be uncontrolled and they're going to have to cancel the procedure that they were NPO for. Most surgeons will not take a patient for surgery if their blood sugar is in the 200s, 300s, 400s, unless it's an emergent procedure. You do not want to be the reason why they had to cancel that patient's procedure. So do the right thing. Call and get an adjusted order for their long-acting insulin if you're concerned about giving it. If the patient's blood sugar is, low 100s or 90, something like that, just give them a bedtime snack with their insulin. If the insulin drops their blood sugars and you're following these guidelines, what does that mean? It means that the dose of insulin that they are on is too aggressive. And so it's up to you to call somebody and let them know that the patient's blood sugar dropped when they got such and such insulin, and ask them if they want to adjust the dose. Okay? You have the power to be proactive. The other thing is, with scheduled insulin, when do you want to hold their scheduled short-acting insulin? You always want to hold it if they're NPO, okay? Because it's designed to be given with food, okay? Now, I tell the nurses at my hospital to hold this short-acting insulin if their blood sugar is less than 100, and that just is, on the safe side. If they hold that dose, it doesn't take as long to get back on track as holding the long-acting insulin, so it's not as big of a deal. And so a lot of times the nurses get nervous giving it if the blood sugar is less than 100, even though patients will frequently take their scheduled insulin at home with their blood sugar 80 and 90. As long as they're eating, they know that that's okay. But usually in the hospital, we'll say go ahead and hold it if their blood sugar is less than 100 or they're NPO. But there's a good chance that when you're taking care of that patient, I'm not on the case. So you need to call whoever wrote the prescription or whoever wrote the order and get parameters, okay? And make sure that the parameters that you have are documented so that you can document why it was held. And then the sliding scale, when should you hold the sliding scale? The sliding scale should never be held because it treats the blood sugars when they're already high. So we want to treat the blood sugars when they're high. We have a Q6-hour sliding scale for patients who are NPO. Just because they're NPO doesn't mean that they don't need glucose control. They still, look at it this way. Would you hold the sliding scale for a patient who's NPO if their blood sugar was 300 or 400? No. So why are you making a decision to hold the sliding scale for a patient whose blood sugar is 157 or 180? Where do you draw the line? Now you're practicing medicine without a license. Where do you draw the line in that decision making? You don't hold the sliding scale on patients who are NPO. You continue to give it to them, and if it drops their blood sugar too low, that means the sliding scale is too aggressive, and that sliding scale needs to be backed down. Because they should be able to tolerate a few units of insulin when they're NPO if their blood sugars are elevated. And then, of course, we have combination insulins, which are combination of long-acting and short-acting. So these can be a little tricky. We don't want to hold them because of their long-acting insulin properties, but we also don't want to give it if the patient is NPO because it has this short-acting insulin in it. We don't want to drop their blood sugars too low. So typically if patients are NPO, they need to be switched to something else besides this combination insulin. They need to be switched to separate long-acting and short-acting insulins. And that's not up to you to do, but you can call somebody and let them know that the patient's NPO and ask them if they want to switch the patient to Lantus and Humalog until after their procedure or whatever, or MPH. Now let's talk about timing of insulin, okay? Let's talk about timing of insulin. it's really important to understand the timing of insulin when you are giving insulin, okay? Here's our timeline. This is bedtime, fasting, pre-lunch, pre-dinner, and bedtime again. So here, we usually give our Lantus at bedtime. Not always, but a lot of times we give our Lantus at bedtime. It takes about 8 hours to see a peak effect of Lantus. So we should see the full effect with that fasting sugar, okay? The Humalog takes about 4 hours, or it lasts about 4 hours. It peaks in about 1 to 2, but it lasts about 4 hours. So about the length between breakfast and lunch, lunch and dinner and bedtime. So when you give their Lantus at bedtime, their blood sugar the next morning should be good. And then you should give their Humalog. They should eat breakfast. Their blood sugar before lunch should still be good. Then they get another dose of Humalog at lunchtime. Then that causes their blood sugar before dinner to be good. They get another dose at dinner time. Bedtime blood sugar should be good. Get their Lantus, and the cycle repeats. We keep their blood sugars nice and controlled. You miss one of these steps, and all of a sudden we have a spike in blood sugar. And so let's talk about what happens when, I want to talk to you about something that I have coined the ping pong phenomenon. Okay? I frequently get consulted about patients who have supposedly brittle diabetes. And brittle diabetes means that their blood sugars jump around a lot. They may go from 500 to 30 in a matter of hours. So I go and I look at their chart, and here's what I see, usually. Sometimes they really are brittle diabetics, but usually I see something like this. Last night at dinner, they got their scheduled, let's say they get 15 units of Humalog scheduled before meals. They got their scheduled 15 of Humalog at dinner time. And then at bedtime, their blood sugar was 79. Okay? So then what did the nurse do when the blood sugar was 79 at bedtime? She did two things, okay? One, she held their Lantus. And the other thing she did was she loaded them up with carbs. Because everybody knows that when your patient has a normal blood sugar, this is not even a low blood sugar, this is like in the normal range, but everybody knows that when your patient has a low blood sugar, you have to give them like 15 things of orange juice with like 20 packets of sugar and like 5 sandwiches in order to get it up. That's what I see in the hospital. I don't see like something reasonable where you give them 1 orange juice and wait 15 minutes and recheck it, and then if it's still low, give them another orange juice. No, we have to make sure that we shoot that blood sugar from where it is all the way up to like 600. So they hold this insulin, they load the patient up with carbs. The next morning, the patient's blood sugar is 450, sometimes higher. Sometimes I see it in the 600, 700s. 450. Now, because their blood sugar is so high, we have to give them extra insulin to bring it down. So first of all, nobody called and let anybody know that that blood sugar was low. So nobody adjusted their scheduled 15 units of Humalog. So now they're going to get their 15 units of Humalog. And let's say they're on a pretty aggressive sliding scale, so they're going to get like another 15. So now they're going to get 30 units of Humalog. And maybe the patient's not eating very well. So now we've dropped their blood sugar again. Let's say we dropped it this time to like 32. Now we're going to do the exact same thing. We're going to hold their insulin and load them up with carbs again. Bounce that blood sugar right back up. And this cycle is going to repeat and repeat and repeat until somebody comes in and breaks the cycle and says, okay, this 15 units of Humalog is too strong. We need to decrease it. Let's go down to 10. So we're going to decrease this to 10. And then what happens at bedtime? Their blood sugar is like, 130. That's, good. So then they're getting their insulin and all this resolves. Or they drop too low at bedtime, 79, but this nurse knows how to manage diabetes appropriately, and she calls the provider and says, hello, my name is Christina, and I am a nurse on such and such unit taking care of your patient, Mr. Smith, and he got his scheduled Humalog with dinner. His blood sugar is now 79. Would you like me to give the full dose of Lantus, or would you like me to give a partial dose? Now we've done something proactive, and the provider says, okay, let's just give half the dose of Lantus tonight. So instead of getting 30 units of Lantus, the patient gets 15. Their blood sugar may still be a little high in the morning because they got a partial dose of their Lantus, but it's not going to be 450. It may be in the 200s, but it's going to be better. That's something that you guys have control over. You can call and get these orders, okay? It's not something that you have to wait until the provider just happens to notice that these blood sugars are ping-ponging back and forth, okay? And most of the time, the providers are not going to look to see why these blood sugars are bouncing around. They're not going to look and see that the Lantus was held and that's why it skyrocketed or this and that. I take the time to do that because that's my sole focus on that patient, is why their blood sugars are bouncing around. But most providers are not. What's going to happen with most providers is this. They're going to see that that patient's blood sugar was 450 the next morning. And they're not going to realize that the patient didn't get that 30 units of Lantus that they were supposed to get. So they're going to increase the dose. They're going to say, okay, 30 units is not enough. Let's bump it up to, 40 units. Okay? And then the next night, the same thing happens, because we haven't fixed the real problem, which is that the Humalog dose is too strong. So the patient continues to get that 15 units of Humalog before dinner, dropping their bedtime blood sugar low. And then every night this is being held. And so every day the provider is increasing this dose without realizing that it's not even being given. And then what's going to happen? One night the patient, maybe they missed their dinner time dose, their blood sugar at bedtime is good, the nurse is going to give this Lantus. And what's going to happen to the patient's blood sugar during that time? The patient's blood sugar is going to bottom out in the middle of the night. Okay, so that's dangerous. You need to let somebody know when the patient's blood sugars are not where they need to be, because a lot of times providers don't realize that. They just assume that the orders are being given. They don't realize that they're being held. Another thing I want to talk to you about is timing of insulin and timing of blood sugar checks. Okay, so a lot of times what we see, here's the way it should be when patients have diabetes. They wake up, they check their sugar, they take their insulin, and they eat within 15 minutes. And they repeat these steps with every meal. Check their glucose, take their insulin, eat within 15 minutes. Check their glucose, take their insulin, eat within 15 minutes. How often does it happen like that in the hospital? Very infrequently. A lot of times what we see is there's a very long delay between the time that the blood sugar is checked and the time that the insulin is given. I have seen insulin given on blood sugars that are 6 hours old. I'm not kidding. What I see frequently is that the night techs check the morning blood sugars, and they don't want to wait to do it until 6 or 6:30 because they're in a hurry to go home. So they check their blood sugars at like 5 or 5:30 in the morning. And then the next morning, the nurse uses that blood sugar to give insulin, but she's running late on her medication, so that insulin doesn't get given until 9:30 or 10 o'clock. That is a delay of 4 to 5 hours, and I've seen even more than that, but that's a delay of 4 to 5 hours between the time this blood sugar was checked and the time this insulin was given. That a lot could have happened in that time to change the blood sugars. Another thing, which is very dangerous to do that. And then another thing you're doing is you're not only giving them their scheduled insulin, you're dosing a sliding scale based off of a blood sugar that is 4 or 5 hours old. If you have to recheck their blood sugar, then recheck their blood sugar. It only takes 15 seconds. It'll save you a lot of time in the long run, rather than having to deal with a patient who's hypoglycemic because their blood sugar has come down significantly since 5 hours ago. The other thing we see is that a lot of times the blood sugars are checked after they've eaten, and so now their blood sugar is higher than it should have been, so we're dosing their insulin based off of a blood sugar that's more of a postprandial blood sugar rather than a fasting blood sugar. We see insulin given after they've eaten. We see insulin given when they don't have any food. They need to eat within 15 minutes, so you need to make sure this meal tray is available before you give the insulin. All of these things are really important, because what will happen is you're going to end up bottoming the patient's blood sugar out. I had a nurse call me one time and tell me that she dropped that a patient's blood sugar dropped into the 30s, and the tone was kind of like, well, you know, I ordered too much insulin. And I was like, okay, well, let me go look at it and see what happened, because the day before the patient's blood sugars had been running pretty high, and I had increased their doses of insulin, but it was a conservative dose adjustment. It wasn't a lot of insulin that I had increased. So I go in the chart and I look, and I see that the nurse gave the patient's breakfast time insulin late. She was running late that morning. She gave the breakfast insulin at 10:30. Okay, and the patient was getting like 25 units scheduled with meals. Okay, which isn't a whole lot. I mean, if somebody's very overweight, insulin is weight based often, so 25 units may be very much appropriate for that patient. And then at 11:45, she turned around and gave the patient their lunchtime insulin. That's a difference of an hour and 15 minutes. An hour and 15 minutes later, she gave their lunchtime insulin. And Humalog and Novolog, and regular insulin, they last for about 4 hours. So if you're giving the insulin an hour and 15 minutes later, there's a lot of overlap there. So it's like you've given that patient 50 units of insulin. And so of course it dropped the patient's blood sugar low. The other thing is that that patient's meal tray didn't come until 12:30. So why did she give that patient's lunchtime insulin so early? She told me, the insulin is scheduled at 11:30. I have an hour before to an hour after to give it. And I told her that may be true with most medications in the hospital, that's what they say. But when it comes to insulin, you give it when the food comes, that mealtime insulin. Otherwise, you're gonna have a hypoglycemic patient. Nobody is gonna fault you for giving that insulin when the meal tray comes, even if it's technically late on your MAR. This is where common sense has to override other things that you've been taught, okay? So this is a very dangerous scenario. It's just as dangerous as giving the insulin 6 hours after the blood sugar was checked, okay? Make sure that when you give them that scheduled insulin, that scheduled 25 units, that they have a meal tray in front of them. Otherwise, their blood sugar is going to drop. If you're really this late passing your insulin, just skip this dose. I mean, is their blood sugar going to temporarily jump up here? Yes, it probably will. But it probably will. But at least we didn't cause them to become hypoglycemic and drop them into the 30s. We always err on the side of caution, and we would rather the patient be temporarily hyperglycemic rather than dropping them too low. So anyways, I hope that I've kind of explained everything in an easy to understand manner. I know I was a little bit all over the place. If you have any questions, feel free to comment in the question section or in the comments section, and I will respond to them. Please share this with anyone who you think may benefit, whether it's patients or providers or nurses, nursing students or whoever. And I look forward to making more videos. Thank you so much. Don't forget to subscribe to my YouTube channel. Thank you.